This webinar is for informational and educational purposes only and is not a substitute for professional medical advice. This information is not intended to provide a medical professional's opinion or advice. You are advised to seek appropriate licensed medical professional help. This webinar discusses clinical trials of drugs or therapy that are not yet FDA approved. Please understand that the time from Phase 1 clinical trials to availability can be significant. Also note that not all clinical trials result in a successful drug approval. Please do not delay treatment based on this or other webinars. Talk to your medical team about available clinical trials or if you have any questions or concerns about your individual care or treatment.
Hi everyone, welcome to today's LACNETS webinar, Exciting Advances in Net Management, Cu64 DOTATATE and Alpha PRRT with Dr. Delpassand. I'm Lindsay Judavine, the Director of Communications for LACNETS, and this is...
I'm Lisa Yen. I'm the Program Director for LACNETS.
And before we get started today, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. You're the best, Rich. Remember, we will be having a live Q&A following Dr. Delpassand's presentation. To submit your non-case-specific questions for today's speaker, go to www.slido.com and enter event code LACNETS, LACNETS. Before we get started, here are a few tech tips for today's webinar. As a reminder for your audio, be sure the volume on your computer is turned all the way up. Also, double-check that the volume is unmuted on the webinar broadcast screen. For the video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. Also, following the webinar, the live webinar, we'll be posting it on our YouTube channel, which is also full of 100+ net videos for your viewing. As a reminder, these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it off to you, Lisa.
Thanks, Lindsay. As you may already know, LACNETS is a program by GeneratePossibility.org, a registered nonprofit, and it stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, which is an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer since we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are led by a team which includes our interim administrator and board member, Kavya Velagapudi, and board member Donna Gavin, also the sister of LACNETS founder and executive director emeritus, Giovanna Joyce Mbasi. Our newest board member is Mary Dunleavy, who is living and thriving with NET. I'm excited to introduce today's speaker, Dr. Delpassand. Dr. Delpassand is the chairman and medical director of Excel Diagnostics and Nuclear Oncology Center, adjunct professor of the Department of Radiation Oncology at the University of Texas, and CEO of Radiomedics. Dr. Delpassand has treated more than 1,000 patients with PRRT, including my very own husband, Tom Bajoris, who you may have heard share his story last April. So I met and got to know Dr. Delpassand through my husband's treatments with LU-177 DOTATATE back in 2016, prior to its FDA approval. We wanted to invite Dr. Delpassand to join us here today, as we know there's been quite a bit of interest in the exciting work he's doing with targeted alpha therapy, also known as alpha PRRT, which may be considered the next generation of PRRT. We will first hear from NET patient Deanne, who was treated with targeted alpha therapy at Excel Diagnostics in Houston, and then we will hear from Dr. Delpassand about the novel agents Cu64 DOTATATE and alpha PRRT.
Hi y'all, my name is Deanne and I'm coming to you today from Austin, Texas. Thank you for asking me to speak about my journey with AlphaMedix and targeted alpha therapy. Little background on me, I am a PNET. My pancreas was in my primary and I had metastasis in my liver when I was diagnosed about 4 years ago. I started off with resection surgery. They removed half of my pancreas, plus my gallbladder, my spleen, the right lobe of my liver, and numerous wedges in my left lobe. Then I immediately started on lanreotide shots. They were to try to stop progression or slow it down because I don't have symptoms. I'm an asymptomatic PNET, so I do not flush, I don't have GI issues and stuff like that. But lanreotide wasn't enough. I was still progressing. So then by that summer, we started on Afinitor. It didn't work, unfortunately, so then we moved on to bland liver embolizations. I had 3 of those. And then after that, with progression, I moved on eventually to Captum. Captum was actually successful. I had about 20% shrinkage right off the bat with Captum. However, I did have platelet issues. I'm in that 1% that has the odd side effect of platelet crashing. So after 5 months of Captum, I had to stop because of my platelets. So then I had progression again, and it was time to pick my next treatment. And we got to the point of either Lu-177 PRRT, or there was the new AlphaMedix targeted alpha therapy trial down at Excel Diagnostics in Houston. And we tried to decide which one to do. So Lu-177 sometimes has side effects issues with platelets, and that was the concern of my specialist, Dr. Liu, in Denver, as well as my local oncologist. What happens if I try Lu-177 and after just one treatment my platelets crash again? Then I can't do any more. Or do I try the AlphaMedix trial in Houston? Because it's alpha, it's supposed to have less damage to stuff around it, and no platelet issues as well had been known. But it is a phase 1 trial, so there's only a handful of people that have been in it before me, so we really didn't know. But when we weighed the two, Lu-177, they say, is like a bullet versus AlphaMedix is like a bomb. So it certainly could help you for a longer period of time. And before this, like I said, I've done numerous treatments, and each one was really just to hold you over for 6 months or a year or so. So I was really looking forward to something that might actually last more than just a short period of time. So then we thought about it and said, you know, you never know why you're diagnosed with cancer and what your purpose is. And maybe this is my calling. Maybe this is what I'm supposed to do. Somebody has to be in the trial, and phase 1 is a bit scary with all the unknowns, but maybe that's why I'm here. And I talked to my husband of 25 years, our 3 children, and we decided this is what it is, that I'm going to go ahead and be the one in the trial. Maybe it helps me, but what if it could help lots of other people as well in the future? Since there's no cure for neuroendocrine cancer, a treatment that could last you for years of stability or shrinkage would be amazing for all of us. So at that point, I called Excel and I got into the trial. I started in December of 2019 and had 4 treatments. When you go, you have a lot of scans because you are in a trial and a lot of lab draws and everything. So it's quite the process, but the staff made it pretty easy, and they were always just great with me and never treated me like a number or a lab rat. So I really enjoyed being down at Excel. As far as the treatment itself, it's just a one long day. For the trial, I'd get there about 8 in the morning, finish up about 5 in the evening. You just sit there with the injection. I get a little nauseous here and there, mainly from the amino acids. It's an original set, much like Lu-177 PRRT when it first began. So the amino acids are a little nauseating. That night, I was extremely nauseous and or vomited each treatment, but really just the first night. Felt better definitely the second day, and was actually able to drive home to Austin from Houston the day after treatment. So it's a 3-hour drive, and I was able to do that by myself with no problems. Then once you get home, you have a 5 to 7 day radiation protocol where you can't be around anybody. So I had lots of time for Netflix over COVID and isolation time in my house. By the end of that, I was fine and good to go until the next treatment 8 weeks later. At day 17 each time, I had heavy hair shedding, and I'm talking heavy. So it came out a lot, and you know, people say it's just hair, it'll grow back. It's not just hair, especially for me. You know, I had a head full of thick hair. A lot of people knew me because of my hair, and to have it fall out so heavily was pretty hard for me to handle. But by now, it's grown back. It's getting there. It's been a year, and I can actually talk about losing my hair now without getting quite so upset. So it has come back quite gray and sparkly, but that's okay because now I do have hair. My eyelashes and my eyebrows and everything are coming back as well. So that was all just a temporary thing after each treatment. Other than that, there's really been minimal side effects. My labs are great. I just have one lab that's a little off. Everything else is good. And as of now, I'm at about 98% shrinkage of my tumors. So my gallium-68 that I had in January, just a few months ago, is as clear as they can say to the naked eye. So my cancer is basically gone. My liver's a bit beat up. It needs time to recover, but I did have a lot of tumors there, innumerable at that. So with the largest being around 3 centimeters. But my liver was like salt and pepper, and now it's pretty clear. So I'm really hoping AlphaMedix is the future of treatment for all neuroendocrine patients, and I'm very thankful to be in the trial. If you have any questions or if you'd like to reach out, please don't hesitate to contact me. I'm more than happy to talk to all of you, and hopefully I can shed some light on AlphaMedix and the therapy that I received. Thank you so much. Y'all have a good day. Bye-bye.
Good afternoon. This is Dr. Delpassand. I'm Chairman and Medical Director of Excel Diagnostics and Nuclear Oncology Center in Houston, and CEO of RadioMedics. Thank you for the introduction. I'm very excited to talk to you about recent advances in neuroendocrine tumor management. My presentation will consist of 2 parts. One, I'm going to talk about Cu64 DOTATATE, a new radiopharmaceutical for PET-CT imaging in patients with somatostatin receptor expressing neuroendocrine tumors. This is a drug that has been recently approved and is now commercially available for our patients. And then I'm going to share with you our latest results related to development of targeted alpha therapy for metastatic or inoperable somatostatin receptor expressing neuroendocrine tumors. As we all know, there are several radiopharmaceuticals that are used for imaging of somatostatin receptor positive neuroendocrine tumors. I remember I was just finishing my residency training here at Baylor College of Medicine in the 80s. Kind of tells you about my age, I guess. Scan was just approved in US. And for the first time, we were able to actually image neuroendocrine tumors that are expressing somatostatin receptors. So this was a specific test for neuroendocrine tumors. And of course, we were using gamma cameras, using a SPECT imaging. Later on, CT was added. So we were doing a SPECT CT imaging to image lesions that are expressing somatostatin receptors. Then later on, obviously, PET imaging was introduced in nuclear medicine. PET stands for positron emission tomography. It's a modality in nuclear medicine that has much higher contrast resolution than a SPECT. It uses the positron emitters, and also it is combined, all the PET scanners are combined with CT scans, so it gives us both functional information as well as anatomical information. So PET-CT was introduced, and we were very excited for having this modality in nuclear medicine. In the 90s, actually, reimbursement started for FDG PET imaging. FDG is another radiopharmaceutical that is commonly used for different type of cancers those cancer cells that they are using a lot of glucose or sugar can be imaged by this kind of a PET scan. So this was, again, another great milestone because of the coverage and reimbursement by Medicare and other insurance companies. Suddenly, we saw explosion of number of PET centers throughout the country. And this was a great thing for our cancer patients. In 2015 and 2018, gallium-68 DOTATATE and gallium-68 DOTATATE received FDA approval respectively in US. At our center, we were doing gallium-68 DOTATATE since 2013, and the approval obviously gave us a great capability of doing PET imaging for patients with neuroendocrine cancer. So this was the PET equivalent of Octreoscan, and because of much higher resolution, we noticed that now we can detect extremely small lesions as long as they were expressing somatostatin receptors. So this is my belief, and I think the belief of people of neuroendocrine tumor community, that if PET imaging is available, really there is no place for performing Octreoscan. I think PET brings a much higher sensitivity and a specificity for detection of neuroendocrine cancers that surpasses Octreoscan. And there are several studies that actually have proven that this is the case. And also, with now having PRRT, targeted radionuclide therapy for somatostatin receptor expressing tumors, the use of and the need for this kind of PET imaging has increased significantly, because this is a test that we need to do with a high sensitivity to find eligible patients or patients who will benefit from PRRT by this test. So this the DOTATATE part is a ligand that actually takes the radioactive material to the site of a tumor, is exactly identical to the ligand that is used for PRRT with lutetium-177. So just moving forward, although gallium-68 somatostatin receptor PET imaging brought a lot of excitement to the field, and of course, it is used very commonly right now, there were some shortcomings related to gallium-68, which comes from the nature of this and physics of the gallium-68. The number one shortcoming was the half-life of this radioisotope was only 68 minutes. What that means is that after the manufacturing, when we have, let's say, 10 millicurie of gallium-68, within 1 hour, the activity is half of the activity. Within almost 68 minutes, we lose 50% of the activity. And that translates into some limitations in terms of distribution of this radiopharmaceutical to different centers. So the centers that they need this radiopharmaceutical, they need to be very close, within maybe maximum 2 hours driving distance from the place that this drug is manufactured. Another shortcoming of this is, because it requires a gallium-68 generator, it's only available in major medical centers, and it's not available in every city of the country. Gallium-68 generator also, because depending on the activity of the generator, which actually decreases by time, we can probably get maximum 3 to 6 doses per day per generator. So that also imposes another limitation that, let's say, in a Texas medical center, biggest medical center in the world, with all these hospitals and imaging centers across the city, etc., everybody is going to fight for getting the dose to their centers, because only 3 to 6 doses are maximum 6 doses. Majority of the time, it is actually 3 doses available for the entire city. So that was another major shortcoming in this. And on the practical side, any kind of a delay in patient arrival, starting IV for a patient, or sometimes, we're dealing with electronics and equipment, and if there is equipment failure, potentially can cause wasting of the drug because half-life is very short and it's just enough that the patient arrives late or difficulty in starting the IV, or suddenly the computer crashes, or you have a short power outage. All these can contribute to significantly decrease the activity of the dose, which again causes problem in terms of having a good high resolution studies. So knowing all these shortcomings, we thought about another positron emitter called Cu64. Cu64 is another positron emitter. The half-life in this one is 12.7 hours, so almost 13 times longer half-life than gallium-68. And it has a 17% beta. Beta is the positron emitter. With the lower maximal positron energy of 0.653, these numbers might not mean so much to some of our listeners, but overall, that tells us that Cu64 actually is very similar to F18, fluorine 18, that is used for FDG PET-CT imaging, which has the very favorable contrast resolution. And this is why our images with Cu64 actually are brighter and we have a much better contrast resolution. So that's on the physics side of the Cu64. And another important part is that this is a cyclotron-produced isotope. What that means is that a cyclotron facility can actually manufacture Cu64 thousands of millicuries every day or in every batch of manufacturing. And this results in unlimited or almost unlimited, how many doses we want to have. It is possible to manufacture hundreds of doses every day. And because of a longer half-life, we can actually ship this overnight to any center across the country with PET-CT imaging capabilities. So that resolves a significant and unmet need related to radiopharmaceutical that can do PET-CT imaging for patients with neuroendocrine tumor that are expressing somatostatin receptors. So this was a great thing to know that we can really respond to these unmet needs by switching the positron emitter isotope of the agent and have all these advantages as compared to the gallium-68. So because of this, we embarked on a clinical trial, the first clinical trial in US, doing a prospective reader-blinded phase 3 clinical trial on this agent in patients with suspected or known somatostatin receptor positive neuroendocrine tumors. We also took advantage of our collaboration with Dr. Kjær, Professor Kjær at the University of Copenhagen in Denmark. They had previously done clinical trials. There were a couple of publications from that center. And we agreed that actually we rely partly on the literature published in this agent in order to go to FDA and essentially prove our case and ask them to approve this drug. FDA definitely required another US study for the approval of this drug. And this is why we started this clinical trial in 2018. Initially, we questioned that, typically in gallium, we are using 5 millicurie, or even in Dr. Kjær's presentations, publications, they use 5 millicurie of the Cu64. But we said, is it possible maybe to have the same diagnostic quality images, but use less radioactivity that translates into less radiation exposure to our patients? There is a principle in nuclear medicine called ALARA, as low as reasonably possible or achievable. And that is in a case that we can use less radioactive material. Obviously, it is preferred to use less radioactive material if we can reach to the same outcome. So for this, we designed an initial phase 1 study on 12 subjects, and we injected them with different doses of 3 millicurie, 4 millicurie, and 5 millicurie. And PET-CT imaging was done on our patients at 60 plus 15 minutes after injection. We used 5 minutes per bed, and we asked 3 experienced nuclear medicine physicians that were blinded to the amount of activity that was injected to the patient, just evaluate the images and answer to questions regarding the quality of the images that they are seeing. And also at the same time, we did some initial safety evaluation to see after injection of the dose, do we see any adverse event in the patients, any changes in the vital signs, any changes in the labs, clinical blood tests, or EKG of the patients. So it was a small study on 12 subjects. And this is the result of that study. We were able to show that actually 4 millicurie works as well as 5 millicurie. Both of group of 4 and 5, they received a score of 7 out of 8. And so we agreed that we were going to go ahead for our phase 3 trial with 4 millicurie instead of 5 millicurie. And in this way, we can actually decrease the radiation exposure to our patients. So the objective of this study, the phase 3 study, was to evaluate the performance of the study in simple language. We look at the sensitivity and specificity. Sensitivity means you can find all the patients, how good you can find all the patients that they have disease. And specificity means how specific is the lesion that we are seeing for neuroendocrine tumor. So anything that is showing up, is it, what percentage is actually neuroendocrine tumor expressing somatostatin receptors and not other things related to inflammation, infection, etc. So this is in simple language defining sensitivity and specificity. So this was our primary objective. And of course, secondary objectives, we wanted to see how the readers, different readers will compare with each other. We had 3 nuclear medicine physicians that were blinded to any information about the patients and subjects, and we want them to see how they correlate with each other and also with themselves. So we were giving them a few cases after several weeks later to read again, and we wanted to make sure that they give the same reading also after a few weeks reading the initial scans. So these were our primary and secondary and tertiary. As I said, intra and inter-readers agreements, we wanted to look at that as well. So here, the total of 63 subjects were enrolled, 42 patients with confirmed the neuroendocrine tumor, 5 suspicious for neuroendocrine tumor, and 21 subjects, healthy volunteers actually. Of course, the readers, they didn't know who is healthy volunteer, they didn't know who is suspicious or has the confirmed disease. So they were totally blinded to all this information. We enrolled 28 men, 35 women with a median age of 54 years old. They all received 4 millicurie plus minus 10% of the drug. And of course, before starting the study, we received authorization from FDA for our investigational new drug application, as well as approval by our institutional review board for performing these clinical trials. So here is one example of a healthy volunteer, just to show the normal distribution of Cu64 DOTATATE. It is almost identical to gallium-68 DOTATATE. We see activity. The bright one in the middle of the skull, in the base of the skull, is the pituitary. It's a normal uptake of the pituitary by this agent. We have salivary glands, parotid and submandibular salivary glands. We have a spleen, which is very bright, kidneys that are very bright. Liver, as you can see, very faint background, which is great for actually detection of lesions in the liver. We have some faint activity in the abdomen, and of course, activity in the urinary bladder. Depending on how much urine is there, we'll see uptake there. So this was normal distribution. And this is another relatively actually difficult case by CT at least. I mean, this patient has peritoneal seeding of neuroendocrine tumor, but as you can see, even you don't need to be a nuclear medicine physician to see all these bright dots in the abdomen and lower pelvis in this patient. Of course, patient has also liver lesion and mesenteric mass in here, but overall, very nicely, even very small lesions that on CT, probably radiologists, they're going to have a little bit hard time to, for sure, saying if this is the lesion or not the lesion, but unequivocally, you can see this in copper dotatate PET CT, and you can call it. So we were very pleased with the contrast resolution of our images. All right, so this is the take-home message and the outcome of our clinical trial, showing the sensitivity, specificity, positive predictive value, PPV, and negative predictive value, NPV, and accuracy of this test. And as you can see, these numbers are extremely good. We're talking about 100% sensitivity, 96.8% specificity, a positive predictive value of 96.7%, negative predictive value of 100%, and accuracy of 98.4%. So these results are obviously extremely good and encouraging and promising. And this is why we received approval of this drug on September 3rd of 2020 in the middle of pandemic, unfortunately. And so FDA gave us the seal of approval, and we were very happy to reach to this conclusion, because now all our patients across the country, they were able to have access to this radiopharmaceutical to do the PET imaging. So in this journey, we were also collaborating with our partner, Curium Pharma. Curium is probably one of the biggest private nuclear or nuclear medicine companies in the world. They're in US. Their base is in St. Louis, Missouri, in Maryland Heights, which is outside the St. Louis, and they agreed to do the manufacturing of this drug and also doing commercial launch and distribution of this drug. So this slide is prepared by them in one of their presentations. So for performing this study, there is no dietary or food restrictions. So patients can have their breakfast, they take their medications, and then they go to the center to have their PET CT imaging studies. We, like any other nuclear medicine procedure, we recommend that the patients, they take a lot of fluid, be very well hydrated, and go to restroom frequently, just to decrease the radiation exposure to the bladder. And also, we want them to have a comfortable clothing so they can stay on the camera, on the table when their imaging is done comfortably and they don't move. So these are all the common recommendations before any nuclear medicine studies. The only drug interaction is having somatostatin analogs on board. Drugs like sandostatin or lanreotide, they need to be stopped about 28 days before the study. This is the current recommendation. If they are using a short-acting one, 24 hours should be enough to stop, and then they can have these imaging studies. All right, so of course, we'll have a QA session. If you have any questions about the copper dotatate, I'd be more than glad to answer after this part. But this one, this is the second part of my study talking about targeted alpha therapy using a radiopharmaceutical called lead-212 labeled AlphaMedix, we call it. This is a sort of a commercial name that we have selected for this drug. It's an analog of somatostatin, again, which we call it the dotatate. And we think actually we having a breakthrough in here, which I hope that I can convince you after showing slides that I have in this presentation. So This is a study in collaboration with our partner Oranomed. Oranomed is a company based in France, but they have offices in Texas, in the north of Dallas, in Plano. Their manufacturing site currently is there. So we started collaboration with Oranomed in 2014. Started talking, and then to 2016 we reached to agreement and started working together for developing an alpha therapy radiopharmaceutical for our patients with neuroendocrine tumor. Excel Diagnostics has been our clinical trial sites, and basically we have had a very good collaboration in doing this. Before going further, I just wanted to say a few words about, again, what are the shortcomings, what are the unmet needs when we're talking about targeted radionuclide therapy. So as we know, we received approval by I mean neuroendocrine tumor community, but this was actually done by a company called Advanced Accelerator Applications in 2018. Later on, Advanced Accelerator Application, or AAA, was acquired by Novartis, so this is now a Novartis company. So they received approval for lutetium-177 DOTATATE PRRT, and this was a huge deal. Many of our patients, thousands of patients now, they have received this treatment with a very good effect in terms of controlling the disease and preventing from progression. Having said this, always we strive for better things, to have better efficacy and better safety profile. So some of the shortcomings that we can mention about the lutetium dotatate or other beta emitters for treatment of neuroendocrine tumors are, number one, we see resistance. We see after a few rounds of therapy, we don't see as good a response in the follow-up therapies. So that's one thing. The other thing is that, of course, after sometimes several years, patients, they start showing progression again. We start seeing new lesions, or some of the previously seen lesions, they become bigger and they show progression. So that is obviously a problem, and we need to start offering other therapies for the patients. And going to the physics and at the molecular level of this and cellular level of the reason for these progressions are typically beta emitters cause single-strand DNA damage. And I have another slide that can describe this better. So this is one of the reasons. These cancer cells are pretty smart, unfortunately, and they can, after the damage, they have capability of repairing themselves. And the DNA is the part that can repair itself and again comes back to activity, which we don't want them to do that. So that's one reason. And potentially beta emitters, they have a longer path length, the longer path that they can travel in the tissue, and therefore they can cause more collateral damage in the tissue, which translates into more potential toxicity in the patients. So these were some of the shortcomings that we were seeing with the beta emitters. And also, if we look at different studies published and also the NETHER-1 trial that led to the approval of Lutathera, the patients with complete response, they are extremely rare. We're talking about 1 to 2% of the patients, they achieve complete response. So that was another thing that we wanted to address. So in this cartoon, you can see that just schematically, we are showing that the difference between the path length of the beta emitter, which is few millimeter actually in the tissue, translates into hundreds of cells, versus alpha emitters, which is, although it's stronger, but it's much shorter path length, maybe only few cells, 2 or 3 cells that is covered by this. And this is what we mean by a shorter path length and therefore less collateral damage in the tissue. So in this slide, we can see there are two types of DNA breakage. One leads into single strand interruption of the DNA, and the other one to double strand on the right side. So the difference is that when the DNA only single strand has been damaged, the DNA has this capability of repairing itself, and it has a normal copy of the DNA that can replicate and make exactly the same strand that it was before, and therefore it can normalize the damage or repair the damage and again come back to grow, and this is why we see the tumor after a while it starts growing again. On the other hand, with the alpha emitter, which has a much higher energy, it can break both strands of the DNA. When both strands are damaged, there is no way the DNA can repair itself, and therefore the cell goes into a pathway that we call it apoptosis and cell death, and the cancer cell cannot survive in this situation, and there is no way that it can repair itself. So this is the main difference that comes from the higher energy of alpha emitters, which is sometimes 400 times of the beta emitters. I compare the destructive force of the alpha emitters to, let's say with beta emitters, a golf ball goes through the window, and when you have an alpha emitter, like a truck goes through the window. So this is how much difference in terms of destructive force we're talking about when we are using the alpha emitter. And since it is very targeted and the path length is so short, then we can see that not only it's more powerful, but it's safer actually, because there is less collateral damage and it's more targeted toward the tumor. That is our goal actually. So here we started this phase 1 clinical trial. This was a non-randomized, open-label dose escalation, a single-center study to evaluate the safety and biodistribution of the DOTATATE or alpha medics. And in this investigational trial, we were using only adult subjects with the tumor that was expressing somatostatin receptors. Of course, our partner in this project was Oranomed. And what I'm showing you in here is the results of our 16 patients that we enrolled in this trial, 7 men and 9 women, median age of 68, ranging from 27 to 75-year-old. And they all had biopsy-proven, unresectable, or metastatic somatostatin receptor positive neuroendocrine tumor with different primary sites. So as you can see, we are not limited to GEP-NET, we are not limited to pulmonary or thymus or any anatomical region. As long as patients, they have somatostatin receptor positive tumors, they were allowed to be enrolled. So this was a dose escalation trial. We have a typical conventional 3+3 design. What that means is that we have different cohorts. Starting first 3 patients, we give them the dose, initially just single dose, just look at any kind of toxicity in the patient. And then if there is no toxicity and there is no side effects, then we increase 30% in the dose and continue like this. And anytime we see effectiveness, then we add to the injections basically. So we go from single administration to multiple administration or accelerated doses, or abbreviation, we use MAD for that. So first in human dose was selected based on our preclinical studies and dosimetries that we had done in the past. And actually we had a publication for that. So these are the inclusion criteria. All the patients, they needed to be more than 18 years old, ECOG or functional performance of the patients between 0 to 2. That we have definitions for this. Typically patients who can do their personal things and they are not dependent on performing daily activities on other people, they are included. A life expectancy of at least 12 weeks, histologically confirmed somatostatin receptor positive neuroendocrine tumor. Also, we needed to have measurable disease by MRI or CT scan, so we can then compare and look at the effectiveness, and all the other appropriate imaging studies such as even FDG PET CT, bone scan, etc. We needed to stop the somatostatin analogs, as we mentioned, for the copper dotatate here the same way. The patients needed to have all previously FDA-approved therapies for their disease except PRRT. So this is a part of the clinical trial that we call it a PRRT naive, meaning that patients, they have not received prior PRRTs at the time of enrollment in this clinical trial. There were some exclusion criteria beside PRRT, of course, known hypersensitivity to gallium or actinitate or any components of the alpha-medics. And as we mentioned, they had to stop sandostatin to long-acting ones 28 days before starting of the study. So this slide shows the actual cumulative dose on patients. We finally, our cohort 3 actually, we achieved some clinical response, and then we were able to safely increase 30% in the dose. So in cohort 4, actually, we saw clear response to the medication and treatment. The cumulative dose was between 18 to 24 millicurie. So each dose is approximately only 6 millicurie of the lead-212 dotatate. Many of you know that for Lutathera, for instance, we use 200 millicurie. So this is why the agent is so powerful that only 6 millicurie will do the job in these patients. So here I want to show you some of the examples, and these are not out of 100 patients. As we said, MAT4 or fourth cohort that we had 3 patients and then expanded because we saw the results, expanded to another 3 patients. So I show you all 6 patients that they have received alpha therapy using lead-212 dotatate. Here is a 64-year-old man with metastatic small bowel neuroendocrine tumor. As you can see on the left, gallium scan shows actually somatostatin receptor expressing tumors in the liver and also in the mesentery. You can see the pointers. So just follow these images. As you can see, the images, the baseline was in April of 2019, then August, then January of 2020, and October of 2020. The last picture is 10 months follow-up after the last injection. And as you can see, this is almost normal gallium scan. Very, very faintly, you can imagine the lesion in the mesentery, but all the lesions in the liver, they're already gone. The patient is doing fine. No side effects, no significant, clinically significant adverse events in this patient. So this was a huge deal. You can just imagine how happy we were. And of course, patient was the happiest in here. So the next one is another gentleman. Very interesting story I have. This patient actually came to us, as you can see on the left, with multiple bone metastases from the skull, in the spine, in the pelvis, multiple bulky lesions in the liver, 47-year-old man. And the primary was actually in the lung, which was resected previously, surgically resected. So this patient, when came to us, was on 3 types of narcotic pain medications because of bone pain, smoking marijuana for the breakthrough pains. And poor him, I mean, he had a hard time even laying on the table in spite of all these heavily treated, anti-pain medications. You can see after 2 injections, all the bone mets are gone. We are seeing the lesions in the liver now much smaller. And then after the following 2 injections, we actually had complete response in this patient. When he came back in in August of 2019, he was already feeling well, stopped pain medications, only taking Advil, sometimes he was saying, and was looking for a nice place in Houston to play golf. So I guess it can't be better than that. And obviously we were extremely happy, and patient was very happy. This patient, now we have about 24 months follow-up. Patient is doing fine. Actually, I have a complaint about him, and that is we have a hard time getting him back to Houston for follow-ups. He doesn't want to come back. He says, I'm not sick. Why you want me back there? So, but we need some information for FDA. So this is why he needs to come back. Anyway, this is the third patient, MAT403, 72-year-old woman with bronchial carcinoid again. As you can see on the left, again, you don't need to be a nuclear medicine physician to see that almost the entire left lung is involved by the tumor. After 2 injections, significant response, and follow-ups, as you can see on the last picture on the right, very mild residual activity, mostly inflammatory process, and actually by CT of the lung, patient does not have any lesion that they can call by CT. There are some fibrosis maybe or post-therapy changes. So this is again another complete responders by RECIST criteria in our group. The fourth patient is this one. As you can see, patient has significantly high tumor burden. Almost every bone is involved on the left. As you can see, all those little dots, those are bone metastases. Huge lesion in the liver. As you can see, it's probably like size orange size lesion over there. So this patient, after 2 injections, we started seeing some response. The lesion is in the liver is getting smaller. And then as you go toward the October of 2020, now many of the bone lesions are actually not seen as well as the initial one. The liver lesions are small. Now we actually can see some of the smaller lesions. Previously, we could not see them because it was probably covered by bigger lesions. But anyway, this is what we call it, at least a stable disease for sure. We don't have any new lesion, but it's not complete resolution. So out of 6 patients, this is the only one that we have this kind of a response. It's not complete yet. But interestingly, at each follow-up, we see some improvement actually. So the drug is still kind of working, but we don't see complete resolution like the other cases that I showed you earlier. So this is another one, 63-year-old man with metastatic pancreatic neuroendocrine cancer. Again, bulky lesions in the liver, as you can see on the first scan on the left. And gradually, by giving the injections, you can see significant improvement in the lesions. And patients by RECIST criteria, which is a radiological evaluation of the soft tissue tumors, shows partial response. And this is considered as objective radiological response in this patient. And our last patient, MAT406, 50-year-old woman with metastatic pancreatic neuroendocrine tumor. As you can see on the picture on the left, more than 80% of the liver is involved by the tumor. There are some lymph nodes in the mid-upper abdomen as well. After 2 injections, you can see very impressive response to therapy. And at the end, the last picture on the right, complete resolution of all abnormalities in the liver. Again, one of our complete responders, she feels clinically extremely well with no side effects. White cell platelet counts, hemoglobin, liver function tests, they all are either within normal range or not clinically significantly elevated. So with these results, we really felt comfortable that we are dealing with a breakthrough at this point. Of course, FDA needs to give us that status, and this is something that at this point we have requested FDA. We have filed an application for breakthrough therapy designation by the FDA, and I'm hoping that sometimes in March we hear from the agency about our request. So in summary, we showed that by dose escalation of the study that we did, we reached to a safe and highly effective dose in this patient, which is 67.6 microcurie per kilogram of the patient's weight with maximum of 6 millicurie. Therapy consists of 4 doses, 1 every 8 weeks, kind of similar to Lutathera regimen. And we saw 5 out of 6 patients, or 83% of our patients, to have objective radiological response in this group. We haven't seen any clinically significant hematological, renal, or hepatic toxicity. No progression as of January of 2021. First 3 patients in cohort 4, they have progression-free survival of 23 months and is counting. Patients, they are well and alive. And for the cohort 2, which was started later on, we have 14 months. Again, all patients alive and doing fine. In conclusion, this is the first targeted alpha therapy that undergoing clinical trial under FDA-authorized investigational new drug application for patients who are having tumors that are expressing somatostatin receptors. We think that these good responses that you saw are the reason for that is high efficacy and limited toxicity of the alpha emitter. And because of this, it can cause irreversible damage to and causing double-strand DNA damage to the tumor cells. And as you noticed, we are not going by anatomical size. I mean, we don't care if it is in the stomach, if it is in the bowel, if it is in the pancreas, or it's a lung. We can treat these patients as long as they have good somatostatin receptor expression seen by their initial PET scan. This drug, hopefully upon approval, can be used as a first-line therapy for metastatic neuroendocrine tumor or unresectable neuroendocrine tumors. And also, we are hoping that with the next clinical trial that we're going to have for refractory patients, for patients who have received PRRT in the past, but they have progressed, this is going to be another option for them so they can receive treatment for their diseases. So in here, I'd like to acknowledge teams at Radiomedics, at Oranomed, at Excel Diagnostics, as well as Rapid team under leadership of Dr. George Seguros did our dosimetry for us for this trial. And of course, and our CRO, Clinical Research Organization, was INCLIN. As mentioned, we are very excited about this drug. We think AlphaMedix is a breakthrough and will bring a lot of hope to our patients who have somatostatin receptor expressing neuroendocrine tumors. So by this, I would like to thank you for your attention, and I'll be available to answer any questions that you might have. Thank you so much.
Dr. Delpassand, thank you so much for your exciting presentations and your message of hope for us all. I know that I'm really excited hearing about this. And it's really interesting. I mean, looking back about 5 years ago today, I was educating myself about PRRT in general, and at that time learning about Lu177 DOTATATE. And it's amazing that now we're learning about a whole new type of PRRT. So we just want to thank you for all your hard work and for coming here today.
Thank you so much. You are welcome. It's a great pleasure for me to be in this program and provide the latest information about the copper dotatate and AlphaMedix. Yes, I mean, for me as a physician who has worked in this space probably more than 20 years, it is great to see how far we have come. And to me, seeing our patients who are benefiting from this kind of a therapy is the biggest pleasure and the biggest payday.
Well, thank you for that. And you know that's personal to me since you treated my husband about 5 years ago. So it's really exciting. So with that, I mean, we have a lot of questions that have poured in, and I thought we could take some of the Copper64 questions first and then move to the Alpha questions. So
if you allow me just one thing, as you know, the presentation was recorded before. I didn't have a chance to thank Deanne for her great presentation. Deanne, thank you so much for sharing your story with all the listeners in this program. I think it is one thing for me to present scientific data, but hearing from a patient who has actually is going through this journey and can see the differences really in her disease is really precious. So thank you so much for sharing your story.
Yeah, thank you. And again, that speaks to the difference, the difference the treatments make, because someone like Deanne, someone like my husband, who you treated with Lu-177 dotatate 5 years ago, now we can go from, instead of just planning days, being able to plan months and even years, and go back to things that we really enjoy again. Thank you for that. Okay. So one of the questions that came up is, are you currently using copper-64 scan in your practice? Or are you still using the gallium-68?
We are currently using copper-64 on all our new patients that they're coming. If there are patients who have been enrolled in the, especially FDA, approved protocols, investigational protocols. If we have started with gallium-68, we continue with gallium-68 just to keep the uniformity. But any new patient that is enrolled, we use copper-64 just because, our patients, they like it, our technologists, they like it because it's very flexible and it works fine. So I think, so the answer to the question is copper-64 is used, but in cases that we have already done gallium-68 under protocol, under investigational trial, we use gallium-68. But if they are routine Lutathera patients, we use copper-64 because essentially the distribution, there is no clinically significant difference in distribution.
Thank you for that. And the next question's similar to that, but I know that like when we talk about different scans, like CT scans and MRI, you can't compare each other. So if someone has had a gallium-68 dotatate and then gets a copper-64 dotatate, can they be compared to each other to decide if there's stability or progression, or do you have to get two copper-68?
No, absolutely. They can do copper-64. As you can see, the ligand, which is dotatate, that's the molecule that takes the radioactive material to the side of the tumor. They are identical ligands, dotatate gallium, dotatate copper. The only difference is the isotope. It's like a lights attached to the ligand. And because of the half-life, because of all the things that I mentioned in my presentation, we prefer copper-64, and therefore we can compare them very nicely. There is no problem in comparing a copper-64 dotatate versus gallium-68 dotatate.
Great, thank you for that. So if there's a NET patient that can get either scan, which one would you recommend getting, and how is this decision made?
Well, I personally, prefer copper just because of the flexibility. I mean, it is a longer half-life, allows us to have a more flexible scheduling. Technologists, they are not going to rush to do the scan, and if there is a problem, as I mentioned in my presentation, they are not going to lose the scan. I think administrators also probably like this agent better because the chance of losing a dose just because of some of these unpredictable issues that I mentioned in the presentation is extremely less. So I prefer copper-64, but in terms of the distribution, both of them are really similar. So we're not talking about any different testing here. It's just the logistics and flexibility is much higher than copper-64 copper-64 and gallium.
And what about insurance?
Insurance, this is what I've heard. Medicare has already given a code for this drug. I think it's going to be effective as of April 1st. We are already in the agenda of NCCN guideline. This is a National Cancer Registry and Cancer Guidelines. So copper-64 will be included in the NCCN guideline, and we anticipate that all insurance companies after that will consider this test as an allowable, allowable test. But you need to check with your insurance companies. As you know, each of them, they have a different rules for themselves.
Yes, for sure. And so, in general, in what percentage of NET patients who are somatostatin receptor positive does disease recurrence show a loss of receptor positivity?
Yeah, this is, of course, is not directly related to our topic, but it is not very common. There are two types of losing the uptake when, for instance, when we do a PET scan. One reason is, as I showed you in some of these cases that I had, is actually response to therapy. When the tumor cells have died, obviously they don't express somatostatin receptor, so this is why you don't see any SSTR positive lesions. But the other one is there are some reports in the literature that suggest that some of these tumors unfortunately become undifferentiated, so they become more aggressive, and at that time they lose the somatostatin receptor expression. So, but fortunately, that is not common at all, and it is very rare to see that phenomenon.
Yes, thank you. Thanks for that. I know it's not directly related to the topic, but there's curiosity. And another question along those lines are, do you know if anyone in the U.S. is doing PRRT for high-grade NET and NECs who, for people who don't have the somatostatin receptors? And if so, has it been successful?
Yeah, I mean, if you go to any centers that they are considered neuroendocrine tumor center of excellence, or they have a lot of patients going to them, and they have expertise in those centers, they do treat patients who do not express somatostatin receptor in their neuroendocrine tumors, and of course, there are ways to treat those conditions. Usually, there are these kind of a tumor. The treatment is more difficult than the one that they are expressing somatostatin receptor.
Thank you. Thank you for that. I know you have a lot of expertise in PRRT in general, so that's really helpful to hear. So moving along to alpha therapy, I think everyone wants to hear answers to their questions about this. Does alpha therapy work better for small or large tumors? And then also, which primary origin does it work best on?
Very good question. There has been a lot of talks in the literature because the path length of the alphas are so short in the tissue. People they had hypothesized that it only works on very small lesions and micrometastases, something like that. And it doesn't work necessarily on larger tumors. I think practically I showed you that in practice that's not the case. Actually, this drug works in larger tumor as long as there is blood flow to these tumors, and as long as they are expressing somatostatin receptor, this should work for the patients regardless of their size. Another question is the primary origin. In our clinical trial, we went only by the functional performance or somatostatin receptor expression of the tumors, regardless of the anatomical area. This is something that I'm sure you know during the NETHER-1 trial for lutetium dotatate, it was limited to GEP-NET, gastroenteropancreatic neuroendocrine tumors. Our therapy design is different in the sense that we really don't talk about anatomical region, we talk about somatostatin receptor expression. And to me, that makes a great sense, because as long as the tumor is expressing these receptors, we can go and reach to those receptors. We can attract those receptors by the drug. And we have seen, as you saw in our limited number of cases, we have had cases originating from pancreas, from bowel, from lung. All these cases, as long as they are expressing somatostatin receptor, they can be amenable to this treatment.
Thank you for that. That's really interesting. I know that for patients, bone spots are really scary, right? It has a layer of meaning because now it's spread to my bones. So one big question that comes up is, how effective is targeted alpha therapy in treating bony lesions?
I mean, again, experience that we have is coming from these patients that I showed you. Of course, now we have expanded that. We have already enrolled 12 patients with the effective dose. And as you saw, very impressive response in the bone lesions. And because of a shorter path length, I can tell you that these patients with significant bone involvement, they didn't show much toxicity. One of the worries that we had is that, okay, if we have a lot of bone lesions, of course, in the bone, we have bone marrow. And this is highly energetic particles. Are we going to cause significant toxicity? This was not the case, and we are not worried about that. And you saw amazing response in the patient that I showed you. I mean, came with significant bone pain, multifocal bone metastases, and after almost 2 cycles of treatment, all the bone lesions were gone. So we feel comfortable that you can actually treat these patients safely with no significant side effects.
Mm-hmm. Thank you for that. And you already answered one of the other questions about the extra risks to the marrow with the increased radiation. Is there anything else you wanted to add with that?
I want to just mention this has been our concern, and of course, this is an ongoing clinical trial. We need to increase to our data and increase to our experience. But so far, with the information that we have, this should not be a problem, and patients safely can get treatment when they have multiple bone metastases.
Great. And speaking of bone, again, I guess specifically, what about the skull-based tumors? So are any patients in your study so far that have had skull-based tumors, and how effective was the alpha therapy with treating these?
I mean, we haven't had any patient with a skull-based tumor at this point that I can remember. But again, to me, as long as, of course, depending on the location of these lesions, I mean, if they are located in a place that is very critical, of course, we got to be careful. Probably we will start with administration of steroids to prevent significant inflammation and sort of impinging on critical regions of the brain. But overall, as long as there is good somatostatin expression of the tumor, patients can be tried with this. But as I said, so far we haven't had any cases, but I'm sure when we continue our clinical trial, we'll have cases with this condition.
Okay. You're saying if you can see it, you can treat it, or you hope to treat it.
In the brain, with some basically making sure that it's not going to impinge on any critical areas of the brain, of course, as long as, and of course, we do pre-treatment evaluation and medications that we can give pre-treatment if we see lesions in the spinal cord or in the brain itself. We have a certain pre-treatment regimen that we need to administer to the patients before doing PRRT.
Thank you for that. Thanks for that answer. And, of course, some people have already gotten Lu-177 DOTATATE or other PRRTs, as you know, other types of PRRT. So how many PRRT retreatments can one safely have? And then can you have the 4 cycles of Lu-177 DOTATATE followed by 4 cycles of alpha?
I answered the last question first. The answer is yes. The protocol that we are designing right now for our, what we call it, the PRRT refractory patients, is that patients after 4 cycles of, for instance, Lutathera, they get 4 cycles of alpha. And this is our protocol at this point. Our experience in this area is still limited. We have only treated a few patients. But so far, they have been able to tolerate the 4 cycles, but we need more patients in this area. But our protocol at this point is designed to allow patients who have received 4 cycles of lutetium, dotatate, or other PRRTs, indium-111 or yttrium-90, if they have come from places that they have received these things, still we allow them to get 4 cycles of alpha. And of course, before each injection, patients will be evaluated to make sure it's safe to give them the next dose. So this is the reason we do all those tests in preparation for the follow-up.
Yeah, thank you. And thanks for the extra caution too. So, along those lines of retreatment, there's a lot of concern about what to do, especially after those first 4 treatments. So is it true that there's that you can get 2 treatments with PRRT that's allowed via Medicare following a previous 4-treatment regime. I'm assuming this person's talking about Lu-177 DOTATATE. And then what are the benefits and risks?
Sure. I mean, there is a body of literature, medical peer-reviewed medical literature that suggests that it is safe to administer 2 more doses after first 4 cycles of the Lutathera. Our protocol at our institution is that we want the patients to be at least stable for 6 months after 4 doses of Lutathera before we recommend 2 more doses. We have, I can say, probably about 40 cases right now that we are evaluating, preparing for publication. Hopefully, we'll have this publication in the next few months. It is safe to do this. We have cases to prove that. In terms of benefit, yes, you can stabilize the disease for further months or maybe a year or a year and a half after 4 cycles by additional 2 cycles. So we will have these results hopefully soon published. In terms of coverage by Medicare, I'm not an expert on that, and I defer this question to people who know more about how Medicare works.
We'll call Susan Cork at your institution. So, this is going to come up a lot. And, I came to you a couple years ago when my husband needed retreatment and asked you this. How would you advise a patient who's considering Lutathera versus alpha, whether it's the first time, and I guess secondly, about retreatment versus alpha?
Sure. I mean, at this point, alpha therapy obviously is not an approved therapy. So depending on whether we have an active trial that can enroll patients for alpha therapy, and also patients, they meet the criteria for alpha therapy investigational protocol. Of course, we always offer our patients all the options that they have. So we will discuss with them about alpha therapy. But this, overall, at this point, our information, of course, is limited to the number of cases that we have tried. We think the results are extremely promising. We think that this will be a huge step forward in treatment of patients with somatostatin receptor expressing neuroendocrine tumors. But Lutathera, on the other hand, is commercially available. It's approved by FDA. The sort of eligibility criteria for Lutathera is more flexible. I mean, we are not doing a clinical trial anymore. So this is based on the patients, based on the physician's decision. After talking to the patient, after talking to them about pros and cons of this therapy, can be offered. So there is no limitation in terms of offering Lutathera. PRRT is more restricted at this point, alpha PRRT. So we have to go by the protocols, and deviation of the protocol is not allowed. So we are kind of limited when we are talking. But we are hoping, this is a hope that we have, that as soon as possible, this drug goes through the registration process, and we get the approval from FDA and makes it available to all the patients who will qualify this treatment.
Okay, thank you for that. And so you mentioned criteria. So what is the criteria for getting into the alpha therapy trial?
Alpha therapy at this point, the ongoing trial that we have, as based on our phase 1, we still can treat few patients that they have previously received PRRT. I don't know exactly how many spots left. We have a principal investigator at Excel, Dr. Rodolfo Nunes. Feel free to contact Suzanne Cork or Dr. Nunes, so they can tell you exactly about if there are any slots available for refractory patients. But we will start our next phase for PRRT naive patients who have not received previously Lutathera or any other kind of PRRT in the past, that we are hoping to start sometimes in late April, early June. We will have the new phase of the study, and we'll open up to patients who have not PRRT in the past, have not had PRRT.
And then in terms of blood counts, labs, are there any certain criteria as well?
Typically, I mean, it's nothing different. Actually, it's very similar to the trial that we had for Lutathera. We usually expect to have adequate number of white blood cells, something like more than 2,500 white cells, the platelet count being more than maybe 100. Hemoglobin, I think it's more than 9 or 10. I mean, obviously, when we are enrolling patients, they will share all these details with the patients, but nothing significantly different from what we had for Lutathera.
Great, thank you. And you kind of started talking about this already. When is the next trial, and is it difficult to get into the trial? So I was just checking to see if there's anything else you want to add to this question.
You know, I don't think it's difficult. It's just a matter of we are limited in terms of number of patients we can enroll. So, you know, as I said, we anticipate starting the phase 2, which is going to be a multi-center trial, by the way. It's not going to be only at Excel. There are at least 3 other centers will enroll patients on that, and they gradually come online as soon as their institutions basically goes through all the steps related to contracting and doing agreements, etc. They can come online and they can start enrolling patients. But we anticipate that probably in late April, early June, we start our phase 2 trial. So please contact Susan Cork. She knows you know, about the slots available, as well as she can also inform patients about other sites that might be, you know, closer to people's home. So she can give all the information.
Okay, thanks. I think that's helpful. And I think that's related to this person's question about where can they get the alpha therapy. I think, you know, if this is someone who has 45% of the liver covered with mets and already had their primary removed. And you touched on that there might be other centers. I don't know if there's more you can share about that, which centers or anything.
Finalized, so I cannot really share the sites. I already told you Excel is one of them, but the other centers, because still agreements are pending, I cannot really say anything. In this case, 45% of the liver involvement is not a problem as long as we have good somatostatin receptor expression. It should not be a game stopper, and definitely we can offer this patient if patient meets the other eligibility criteria.
Thank you for that. Another question is, what is the maximum number of allowed treatments with the lead-212 PRRT, and can it be repeated?
Sure. Well, at this point, our protocol calls for 4 cycles. Every 8 weeks, patients, they get 1 injection, very similar to Lutathera. Whether we can repeat this down the road in case after the 4 cycles, patients, they experience recurrence, you know, this can be a subject of another clinical trial. At this point, we do not have any experience in repeat treatment. But what I'm hoping is that these 4 cycles actually does the job, and we don't need to treat the patients again. I mean, this is my wish and this is my hope. I mean, and this is human being. We can hope. And this is my hope that really, because of the effectiveness of this, we cause permanent damage to the cancer cell that it cannot recover itself. So I don't know. I mean, can we talk about cure? So this is my hope.
Yeah, thanks for hoping. Hope is a powerful thing for sure. So, you know, you talked a little bit about the dose escalation and dosimetry. I touched a little bit. So what type of dosimetry is performed before and after the 4 cycles of alpha?
Well, dosimetry, as part of the as part of each injection, we do dosimetry. We have already completed, or at least, you know, this is a question that we are asking FDA. We have done dosimetry on previous patients, and our question for the agency is, would this be adequate? Do we need to do more dosimetries? But typically, dosimetry is done when you give the injection and then ask the patient to come back for a few days after the injection, so we can do multiple imaging through whole body imaging, and also draw samples of the blood and urine. And then we give all this information to our physicists so they can calculate the dose to each organ and also calculate the dose to the tumor. So this is what dosimetry means. And usually there, in any investigational trial related to radionuclide therapy, this is required in certain number of cases. And I think the decision is between a sponsor and FDA to reach to an agreement that how many subjects they need to have dosimetry for any kind of radiotherapy ligand.
Thank you for that really clear explanation of dosimetry too. And talking about criteria, are there any Ki67 limits to be treated with alphametics? And for example, if they're well differentiated but a higher grade, will alphametics be effective?
Great question. As you saw in my presentation, I didn't talk about Ki67. So, and in fact, among the patients that you saw, some of them, they had much higher Ki67 than 20. By criteria, they are considered G3. So no, at this point, we have not put any limitation of Ki67. As long as patients' tumor, they are showing somatostatin receptor expression, they can be enrolled. And this is our current protocol right now.
Thank you for that. That's really exciting, especially for the higher grade and the higher Ki67. So, burning question, of course, is this still a concern of leukemia and lymphoma? Does it still exist with this new alpha treatment?
We haven't had any cases so far. In fact, labs, we haven't seen any significant change. I mean, I have treated more than 1,000 patients with other agents from indium-111 to Lu-177 somatostatin receptor agents. We see in those cases, we see probably maybe 1 to 2% chances of having hematological disorders such as myelodysplastic syndrome or leukemia. But so far, our numbers are too small to say anything like there is none, for instance. I cannot claim that. This is always a concern. It's a very rare condition, of course. Even with Lutathera, the previous experience, as I said, is not more than 2%. But we will watch the patients very carefully for any of these. We know that additional prior therapies, such as cytotoxic chemotherapies, can add to the sort of a probability of developing leukemia or lymphoma in these patients. But overall, I can tell you the risk is much lower we have seen in radionuclide therapies. With alphas, I'm hoping that even it's lower than beta emitters because of all the characteristics that we discussed about the shorter path length, etc. So hopefully it's not going to be a problem.
Yeah, thank you for that. That's really exciting. This is another good question. When should targeted alpha therapy be initiated? With liver progression, what degree of progression, or is the lack of symptom control a good reason?
Well, overall, our protocol requires progression when we enroll the patients at this point. Having said that, I can foresee that in the future, when the drug is approved, I think still the first line of therapy, as you know, if a lesion is amenable to surgery, a curative surgery comes first. Patients, if they have a primary lesions only, that they can do the surgery and remove the tumor. That's first, number one. Number two, starting somatostatin analogs, drugs like sandostatin, lanreotide, etc. I mean, these are the second line, can control the disease for a while and also can control the symptoms in patients who have functional NET. I think that if we are dealing with metastatic disease in the future, I think then going to things like alpha therapy, PRRT, I think will be indicated and will really help patients not only to control their symptoms, but also control the cancer. I mean, yes, symptom control, obviously, if that's the only problem and we have, disease that is very dormant and it's not progressing, I mean, can be done with non-radioactive treatments. But We have seen actually before even changes anatomically in the lesions, if the patients have functional NET and they have symptoms, actually we see the improvement in their symptoms much earlier than even effect on the anatomy and shrinkage of the disease. So the benefit in symptom control.
Yeah, okay. Thank you for that. And speaking of symptom control, what's your protocol with the long-acting somatostatin analogs when people are receiving the alpha? I know you mentioned holding it, but do they receive the injections then in between the treatments or stop it altogether during the 4 cycles?
No, we kind of go like a Lutathera protocol that we had. So patients, they need to stop it about 28 days before getting their treatment, but they can get 1 injection after the treatment. Within even a couple of days after treatment, they are allowed to get 1 injection between each therapy. And then after the 4 doses, if their oncologist feels or we see that the patients still can benefit from cold sandostatins, we have no objection if they want to continue their somatostatin injections.
Okay, thank you for that. And that answered another question too about following up afterwards. But what's the post-radiation protocol? I know Deanne mentioned that. She touched on that. But what is the post-radiation protocol with alpha therapy, and how does it differ from Lutathera?
Almost similar, although we think that probably alphas are safer because it's much shorter pathway. I mean, it's not the alpha. It's a alpha or lead-212 has another gamma ray that that is basically the main concern for any kind of precautions after treatment. So precautionary measures are similar to Lutathera. Most of it is common sense. We tell the patients to don't share your personal stuff, like utensils or, I don't know. I don't think anybody uses that, but toothbrushes, anything with other people or these things like that. But, for the first few days, we want them to, for sure, avoid contacting pregnant women. And also, if they have small kids at home, definitely they need to be in a separate bedroom and using a separate bathroom. Majority of these precautionary measures, they are similar to Lutathera and similar to most of other radionuclide therapies that we tell the patients, and they are treated in an outpatient setting.
Thank you so much. That helps. I think that eases a lot of people's mind. I think we can end with this question. I can't believe how fast this time has gone, but a couple people asked the same question twice. So any estimate when alpha PRRT can become readily or widely available to the public?
Well, at this point, our timeline and our hope is that by 2024, we'll have this drug available for our patients. All depends on, obviously, how fast the clinical trial will move forward. And we are in close communication with FDA. They have been extremely receptive to us, and we are communicating anytime we have a question, and they readily respond to us. We are also meeting with FDA in the next month, again, with some of the questions that we have. It's a collaboration, obviously, and we hope that we can get this to the finish line as soon as possible. And I think 2014 will be achievable, with the way that we think about the effectiveness of this drug and how helpful is this for our patients. I think 2014 will be a good guesstimate.
So 2024, we'll mark our calendars. And you kind of touched about maybe expanded.
2014. I'm so sorry. No,
It's okay.
No, 2024. I'm so sorry.
What about compassionate use or expanded access?
It's always possible. It's a decision that case by case we need to make. We have had one case that therapy was offered on a compassionate basis. But, again, this is a case by case. I personally am for, providing access to our patients. under compassionate use FDA under right to try law. But again, we need to look at it case by case. I cannot promise anything without knowing exactly about the history of the patient, why we need to go that route. If they can be eligible for sure for the trial, we try to include them in the trial rather than going in different pathways.
Yeah. Well, thank you, Dr. Delpassand. Thank you for all your hard work, your dedication, your advocacy and collaboration with the FDA to find more options for NET patients in the NET community. These give us more tools in the toolbox. And as you said, give us hope. And you're hoping for us on our behalf, and you're fighting for us. And just on behalf of LACNETS and the community, we just want to thank you from the bottom of our hearts.
Well, thank you so much. It has been my pleasure. Again, I would like to acknowledge our team at RadioMedics, at Oranomed, at Excel Diagnostics. We also received an NIH grant for this trial, and it has been extremely helpful to us. As you know, conducting clinical research is not cheap, and it requires good fundings. And I really would like to appreciate NIH for the grants that they have given us. Our other partners at Rapid as well as InClean, they have all been integral to this project. So it is a big team working on this, and I am only representative of our whole team at all these institutions that I just mentioned.
Well, thank you to the whole team and all of the collaborators and partners, because you do give us hope. And, as you saw from Deanne's story, and you've heard from my husband's story, right? These patients, you can change lives, and you are changing lives. So thank you for doing that.
It's my pleasure. Thank you so much for having me on this.
Okay. Well, now back to you, Lindsay, in the studio. Thank you again, Dr. Delpassand. Well, take it away, Lindsay.
Thank you so much, Lisa and Dr. Delpassand. As a reminder, please be sure you're following LACNETS on social media. We have Facebook, Twitter, and Instagram. You can stay up to date on upcoming webinars and net news. Today's webinar is being recorded and can be viewed on our YouTube channel shortly after the live broadcast. And now back to you, Lisa.
Thank you, Lindsay. We understand these are challenging times, and we offer many programs and resources, including our weekly NET support group, our monthly NET caregiver support group only for caregivers, NET Vitals, which is a downloadable patient-physician communication tool to help you prepare for your upcoming medical appointments, and health coaching available to NET patients or caregivers. We encourage you to go to our website to find out more information about our programs and view resources, read blogs, take the NET quizzes to check your understanding of all the information you're learning, and much more. We have many exciting upcoming webinars with a phenomenal list of speakers planned through August. Join our next webinar on April 13th with Dr. Lisa Baudet from Memorial Sloan Kettering Cancer Center in New York City. Dr. Baudet will be joining us to discuss PRRT 3 years after its introduction to the US, where we are and where we're going. In May, Dr. Aman Chauhan will be joining us from the University of Kentucky to talk about clinical trials, the latest and the greatest in NETs. In July, our special guest speaker, who joins us every year, Dr. Eric Liu, will be giving a talk called It's a Marathon, Not a Sprint. We're excited to unveil our incredible lineup of speakers for our virtual 2021 LA NET Patient Education Virtual Conference and share that our registration is now open. So you can go on our website and register. Thanks again to our speaker, Dr. Delpassand, for your message of hope. Thank you, Rich from TVP Live, and thank you to all of you for joining us today. See you April 13th for our next webinar. Goodbye.
Bye.
This webinar is for informational and educational purposes only and is not a substitute for professional medical advice. This information is not intended to provide a medical professional's opinion or advice. You are advised to seek appropriate licensed medical professional help. This webinar discusses clinical trials of drugs or therapy that are not yet FDA approved. Please understand that the time from phase 1 clinical trials to availability can be significant. Also note that not all clinical trials result in a successful drug approval. Please do not delay treatment based on this or other webinars. Talk to your medical team about available clinical trials or if you have any questions or concerns about your individual care or treatment.